Hello, everyone. My name is Gurjat Basra, and I'm the Manager of Patient Programs, Research, and Advocacy here at Lymphoma Canada. I am pleased to welcome you all to the first live session of Day 2 of our conference titled What's Coming Down the Pipeline for Lymphoma Therapies. Just before we start, I do want to go through a few housekeeping items. This Zoom software does not allow you to access your camera or turn on your microphone. So if you do have a question, please be sure to enter it into the chat box option at the bottom of your screen. Additionally, this webinar will be recorded and it will be available on our website shortly after the conference, and you will also receive an email with the links to access these recordings. With that said, to introduce our speaker today, we have here Dr. David McDonald, who is a hematologist at the Ottawa Hospital and assistant professor in the Department of Medicine at the University of Ottawa. He's a member of the Scientific Advisory Board for Lymphoma Canada, and he is also the chair of this year's conference. You may remember him from the opening remarks yesterday. His clinical and research interests are in clinical trials of novel therapies in lymphoma and CLL. Thank you, Dr. McDonald, for joining us today, and you could get started as soon as you're ready.
Great. Thank you, Gurjit, and thank you for that introduction. Certainly a pleasure to be here, and I want to thank everybody who's here in attendance today. So I'm going to talk about what's coming down the pipeline with lymphoma therapies, and it really is a challenging topic because there's so many things that I'm excited about. And Gurjit mentioned to me that maybe I had a lot of detail and a lot of slides, but with my excitement over what's happening in lymphoma, it was hard to really choose what to cut out. So we'll go through it rather quickly. Hopefully, I'll leave some time for questions. I cannot see the chat box as we go through. So if there are questions that come up through the chat, I might have to address them at the end of the presentation. These are my disclosures. So lymphoma, it's diverse. It's one disease with many subtypes, and each of the subtypes has a different biology. There are different pathways that are activated within the cells, and that's both a good and bad thing. It's bad because it's complicated for us to sort of understand how to treat different patients differently. But the good news is that creates many different potential targets for novel therapies. For decades, we did rely on chemotherapy, and I'm not going to say that those decades were wasted, because we certainly did a lot of clinical trials with conventional chemotherapy that resulted in treatment regimens that were very effective for lymphoma. So we made a lot of gains with chemotherapy. But the unfortunate thing about chemotherapy is, of course, there are side effects. And so there is certainly a desire to move away from conventional chemotherapy to targeted therapies with fewer side effects. And so there have been many discoveries over the past decades that have led to a move away from traditional chemotherapy. And the two that I'm going to highlight, or the two areas that I'm going to highlight during this presentation, would be immunotherapy, that is therapies that harvest the ability of the immune system to attack the cancer cells, and also targeted therapies. And usually we think about oral small molecule medications that target pathways within those cancer cells. So I do think that we are moving towards a chemo-free regimens in lymphomas and CLL. And 5 years ago, if you had talked to me about this concept of chemo-free, I didn't really like that phrase, because I think that it sort of invokes an image of treatments that have no side effects. But chemo-free is not side effect free, but certainly the side effects of these novel agents are less than those that we see in conventional chemotherapy. Some novel agents work best in certain lymphoma subtypes, and that creates another challenge for a 50-minute presentation that's supposed to cover all of the different types of lymphomas. So I will be describing different therapies, and I may give examples of their use in one type of lymphoma, for example, in diffuse large B-cell lymphoma, but they may also be simultaneously under development in other lymphomas like mantle cell lymphoma or follicular lymphoma, and so on. So I'll do my best to try to keep things as broad and applicable to as many of you as I can. I'll highlight several of these novel therapies, and I'll show how treatment algorithms have changed for a certain selection of lymphoma subtypes. Again, I can't do it for all of them. So let's talk a little bit about conventional chemotherapy. This is where we're coming from. So chemotherapy, it works by targeting cells that are in the process of cell division or cell growth, what we call cell cycle. And different types of chemotherapies may attack the cell cycle in different ways, which is the reason why we have been able to combine different agents in multi-agent chemotherapy in order to take advantage of the fact that each of them might have a slightly different mechanism of attacking the cancer cell. We do know that cancer cells in lymphoma and in all cancers, really, they arise from uncontrolled cell growth and division. And cancer cells tend to divide more frequently than healthy cells. So if you're applying a treatment that affects dividing cells, even though it's not targeted for the cancer cells will be disproportionately affected by those treatments compared to normal healthy cells that aren't dividing all that often. So the problem, though, is that while chemotherapy does affect the cancer cells, it also can impact normally rapidly dividing healthy cells. So that would be cells in our bone marrow, our skin, our hair, and in the lining of our intestines. These are areas where cell growth has to be rapid to replenish cells that are lost through normal wear and tear. And so as it happens, when you have side effects on these rapidly growing cells, you have those types of side effects, including hair loss and nausea and low blood counts and so on. So this slide just sort of encapsulates what we would be considered as the standard conventional chemotherapy in several of the diseases. So ABVD has been our standard treatment for a very long time in Hodgkin lymphoma. On the left, we have CHOP-R, which has been our standard frontline treatment for diffuse large B-cell lymphoma. On the right, we have FCR, fludarabine cyclophosphamide rituximab, again, a standard chemotherapy recipe for chronic lymphocytic leukemia that is almost obsolete now. And on the bottom, we have bendamustine and rituximab, our frontline treatment for follicular lymphoma. And at this point, I should point out that we define a word called chemoimmunotherapy, which is a combination of chemotherapy with a monoclonal antibody. So in this case, rituximab, it's a monoclonal antibody. I'll describe it in the next slides. But it's really an immunotherapy that's been attached to chemotherapy. So we have had access to immunotherapy in lymphomas now for really 20 years or more. So again, I'm going to focus the presentation on what you might call chemo-free therapy with these two major categories, immunotherapy and targeted therapies. So what is immunotherapy? I can remember almost 10 years ago seeing a new patient with CLL, and fortunately for that patient, it was somebody who was in the watch and wait phase before needing treatment for her CLL. But she did say to me one day, I don't want chemotherapy, I want immunotherapy. And at the time I said to her, well, what do you mean by immunotherapy? And her answer was really probably as vague as my answer would have been at the time, because I think that there's been a lot of discussion. This is a buzzword, immunotherapy, and probably because this has been a very effective treatment in really bad diseases like metastatic melanoma, for example, where so-called immunotherapy has made huge inroads into how patients are treated. And it's marketed as non-chemotherapy or chemo-free treatments. But what is it? It's treatment that recruits the immune system to attack cancer cells. That's the simple definition. So how do we know that the immune system has a role in treating or preventing cancer? Well, we do know that patients who have autoimmune diseases like lupus, for example, or rheumatoid arthritis, those patients have a higher risk of developing a lymphoma in their lifetime. And that's because their autoimmune disease causes a dysregulation of their normal immune system. And that dysregulation of the immune system prevents the immune system from doing its normal job of cancer surveillance. So you may not have known this, but the immune system is responsible both for fighting infection, but also it has this cancer surveillance role where when a cell in our body mutates, the immune system recognizes that that mutated cell is not normal and will attack that in the same way that it might attack a bacteria. The second sort of example that proves that the immune system has a role is post-transplant lymphoproliferative disorder. So this is usually diffuse large B-cell lymphoma, and it arises in patients who have had solid organ transplants, like kidney transplants or heart transplants, or liver, for example. And the reason it happens is because the treatments that are used in those patients to prevent their bodies from rejecting those transplanted organs are immune suppressing treatments. And when they are that significantly immune suppressed, again, this surveillance role of the immune system is lost, and therefore lymphomas can develop. So PTLD is a classic example of failure of the immune system to prevent cancers from happening. So what are some examples of immunotherapies? Well, we have monoclonal antibodies like rituximab that I just spoke of. We have antibody-drug conjugates. Now, I put that in brackets because technically antibody-drug conjugates aren't immunotherapy, but it's a medication that's attached to a monoclonal antibody, and so it gets delivered directly to the cancer cell, and I'll show you examples of those. Checkpoint inhibitors really are the sort of the original immunotherapy that we talked about. Now we're talking about CAR T therapy, which stands for chimeric antigen receptor T cell therapy. And we're starting to talk about bispecific T cell engager therapy, or BiTEs. And if you have lymphoma, or if you know somebody who has lymphoma, then I'm almost certain that you've heard of either CAR T or BiTE therapy, because they're really quite well discussed now. So back to the original, so monoclonal antibodies, and in the top right of the screen here, you can see a sketch of what a monoclonal antibody looks like. It has two ends, so it has this top end, which is sort of the arms of the Y, and in this top end, what we have is receptors for specific antigens. An antigen is a protein, and so if this is a target cell here, you can see that these sort of flags on the surface, those are the antigens or the proteins. And these are the antibodies showing where the antibody sort of attaches to the protein. Now, monoclonal antibodies like rituximab, they're specific for one antigen. And so the perfect example of this is the B-cell lymphomas express CD20 on the surface of the target cells. So CD20 is the target antigen, and rituximab is a monoclonal antibody against CD20. So that's the antibody, that's how it interacts with the target cell. And what happens then is these different features of the immune system then recognize that the target cell has antibodies attached to it. And so to this natural killer cell, or to this macrophage, when they see a target cell coated in antibody, it looks to them the same as a bacteria that's coated in antibody. So they say, hey, that's a cell that isn't supposed to be here. And then the immune system does its thing to remove that cell. So that's immunotherapy, monoclonal antibodies. So rituximab was the first. It's anti-CD20 monoclonal antibody. Obinutuzumab is another anti-CD20 monoclonal antibody. It came along after rituximab. It's actually made by the same manufacturer as rituximab, and it is more potent as a CD20 antibody than rituximab. And then we have tafasitamab, which is a newer monoclonal antibody. It's targeted against CD19, so a slightly different protein target on the surface of the cell. And I'll talk about that sort of in combination with other treatments as we go along. Next, we have antibody-drug conjugates. So if this is the antibody, let's say that this is an anti-CD20 antibody. Now, if we attach a drug to that, that antibody still has the ability to find the antigen on the surface of the tumor cell. So if this is an anti-CD20, then this would be CD20 on the surface of the B cell. The antibody drug conjugate attaches to the antigen, and then the whole thing is brought inside the cell, and then that drug is released intracellular. And so that's targeted delivery of the payload. So for example, brentuximab vedotin is an antibody drug conjugate where the antibody, brentuximab, is an anti-CD30 antibody, and vedotin is the drug. Vedotin acts in a similar way to the Vinca alkaloids like vincristine and vinblastine. So the brentuximab finds cells that have CD30 on their surface. Now, what cells express CD30? Hodgkin cells and certain T-cell lymphoma cells. So brentuximab vedotin has been developed in Hodgkin's and in T-cell lymphomas as an antibody-drug conjugate with good results. Polatuzumab is an anti-CD79 antibody, again attached with the same thing. CD79 is expressed on many of the B-cell non-Hodgkin lymphomas. Loncastuximab is an anti-CD20 as well. This time it's attached to a different drug, again, investigated in B-cell lymphomas. And Camadinlab-tesirine is an anti-CD25 antibody, and that's been developed in Hodgkin lymphoma, where the Hodgkin cells present CD25. So I'll just go through a few examples of these, demonstrating where they've been investigated and how well they work. So brentuximab vedotin, that we kind of refer to as BV, it was first looked at in a phase 2 study in patients with relapsed Hodgkin lymphoma. Most of these patients would have had their ABVD up front, then they relapsed, and then they had an autologous stem cell transplant. And then unfortunately, they relapsed again after autologous stem cell transplant. And at this time, when this drug was being developed, there really weren't good treatments for patients who had relapsed after 2 prior therapies in Hodgkin lymphoma. So when they tested this antibody or this antibody drug conjugate in those patients, they found an overall response rate of 75% and a complete response rate of 34%. I can tell you that those numbers are phenomenal. Other drugs that have been investigated in this area would have had maybe an overall response rate of 40% and a complete response rate of 10%. So very exciting, and it led to the approval of brentuximab vedotin for relapsed Hodgkin lymphoma. Then along came the Echelon-1 trial, and that was looking at brentuximab vedotin. If it works so well in these very refractory relapse patients, how well might it work if we add it to conventional chemotherapy and upfront treatment? So this trial was a randomized trial of brentuximab vedotin with AVD versus the standard ABVD in untreated advanced Hodgkin's. And what this showed was that there was a 23% reduction in the risk of progression, death, or need for new therapy. So, that's a significant improvement in the results in these patients with advanced Hodgkin lymphoma, leading to the approval and the funding of brentuximab vedotin with AVD as part of the upfront treatment for patients with advanced stage Hodgkin lymphoma. Now, in T-cell lymphoma, anaplastic large cell lymphoma is a type of T-cell lymphoma that expresses CD30 as well. The Echelon-2 study was an upfront treatment of BV-CHP versus CHOP, CHOP being what was considered the standard. And you can see that in the CHOP arm, the median progression-free survival, or you can think of that as how long the remission lasted on average, was only 20 months with CHOP, our standard. But when you added BV and took out one of the drugs in CHOP and used BV-CHP, the median progression-free survival was improved to 48 months, so more than doubled. And this reduced deaths by 34%. So there was an overall survival advantage. So BV-CHP is now approved and funded as part of frontline treatment for anaplastic large cell lymphoma. So moving on to another example, polatuzumab vedotin. I said that that's an anti-CD79 antibody with the same drug attached to it. This was studied in relapsed diffuse large B-cell lymphoma. This was a randomized phase 2 study looking at BR as a treatment regimen for relapse disease and comparing it to the addition of polatuzumab with BR. And you can see again here, complete response rates 40 versus 17%, overall response rate 62 versus 25%. So significant improvement in the number of people that responded to this treatment. So Pola-BR, again, it's an approved and funded treatment in most provinces in Canada for patients with relapsed diffuse large B-cell lymphoma. So if Pola-BR works that well in relapse disease, let's try it in frontline treatment. So the Polarix trial was a phase 3 study of Pola-R-CHP versus R-CHOP in previously untreated diffuse large B-cell lymphoma. And this study was also a positive study. So there was approximately a 7% improvement in the proportion of patients that were progression-free at 2 years when you added Pola-BR or polatuzumab to R-CHOP as frontline treatment. There was no significant difference in overall survival. And so the results of this study actually have been debated quite widely. And the decision has been made so far not to fund Pola-R-CHP in frontline diffuse large B-cell lymphoma. But now the investigators and experts like myself are going back and looking at the data and saying there may be a subpopulation of patients with diffuse large B-cell lymphoma who would have a much more benefit than what the study showed in the whole population. Loncastuximab tesirine is another example. This is an anti-CD20 antibody with tesirine, which is the drug that's attached to it. 2 trials here. The LOTUS-2 trial was a single-arm trial in relapsed refractory diffuse large B-cell lymphoma, showing 24% of people had a complete response and almost 50% overall response. So again, in those patients with very refractory disease, these are very good numbers for an experimental treatment. Let's try it in combination. So the LOTUS-3 trial combined it with ibrutinib, and I'll talk about ibrutinib later, in relapsed refractory diffuse large B-cell lymphoma, and now we're seeing really quite high overall response rates. So an overall response rate of 57% in the whole group, but we divide diffuse large B-cell lymphoma into patients who have germinal center B-cell lymphoma and non-germinal center B-cell lymphoma. That's getting a little bit into the weeds, but essentially it's identifying that within diffuse large B-cell lymphoma, there's a higher risk group that has non-GCB and a lower risk group of patients that has GCB. And you can see the overall response rate in that lower risk group was 77%. Again, these are very refractory patients where you would not expect anything to have such a significant improvement. And then finally, camidanlumab tesirine, or what we call CAMI-T. This is an anti-CD25 antibody, and it's been tested in Hodgkin lymphoma. I had the privilege to treat one of the patients on this trial. And again, she had 5 prior lines of treatment for her Hodgkin's lymphoma. There was nothing left really that we could try. We put her on this study and she had a complete response, as did 33% of the patients on this study. So very exciting, and I think that this is one that we'll be watching out for in the future. So now I'm going to shift my attention to the next sort of class of immunotherapies, and that's immune checkpoint inhibitors. Now, what this cartoon shows is one of the mechanisms that cancer cells use to evade the immune system. So again, the T cells are part of the immune system, and I've said already that the T cells have a function in removing cancer cells. That's part of what they do. But what happens is that some cancer cells will develop this ligand called PD-L1. So there's a receptor on the surface of the T cell called PD-1. And if a cancer cell expresses PD-L1, L stands for ligand, so that's the receptor for PD-1. If these PD-1 and PD-L1 are attached to each other, what it does is it turns off the T cell. So the T cell and the cancer cell can go along in the body elbow to elbow, but nothing will happen because the T cell is turned off. So inhibitors to PD-1 or inhibitors to PD-L1 can block the receptor sites there and prevent this interaction from happening, which would look like this. So if this antibody is an anti-PD-1 antibody like pembrolizumab or nivolumab, it's administered to the patient, it's circulating around in the body, and what happens is it attaches to this PD-1 receptor and prevents that PD-1 from binding to the PD-L1. And therefore, that T cell is not turned off, and it's again allowed to attack the cancer cell. So it's really quite sophisticated and very targeted. So I want to go through just a couple of examples of immune checkpoint inhibitors that have made an impact on the treatment of Hodgkin lymphoma. So the first is nivolumab, and it was first studied in relapsed Hodgkin lymphoma. This was the Checkmate 039 study. And again, this was a study that was done in patients with relapsed and refractory Hodgkin lymphoma who had had a prior transplant, had a number of prior therapies. And at the time, the only thing that was available now was brentuximab vedotin, right? Because we now know that that's an effective treatment in this population. But when they used nivolumab, they had an overall response rate of 87%. That's a number that you never see in a phase 1 study. So this had incredible efficacy in relapsed Hodgkin lymphoma. The complete response rate was 17%. So then they said, okay, well, let's see how well it works in patients who failed their ABVD, failed their autologous stem cell transplant, and failed brentuximab vedotin. So a very refractory group that would, again, at the time, there would be no effective therapies available for these people. So that was the Checkmate 205 study, and that was a phase 2 study in those very refractory patients. And again, extremely high response rate, 69% overall response rate and 16% complete response rate. So I'm not sure if those numbers are impressive to you, but certainly knowing what those patients would be facing in the absence of this really was incredible. So that's nivolumab. Let's move on to another in this class, pembrolizumab. And again, it was developed in the same way. So the Keynote 087 trial was a phase 2 in Hodgkin lymphoma that had relapsed after auto transplant and after BV. And again, very similar numbers. So an overall response rate of 69% and a complete response rate of 22%. So along comes this Keynote 204 study, which is a randomized controlled trial of pembro versus BV. So you have patients who relapse after ABVD, they relapse after auto transplant. You know that BV works very well in these patients. You know that pembrolizumab and nivolumab work very well in these patients. Which one of those is better? Which should we choose as the third line treatment? So this phase 3 trial in those patients showed that pembrolizumab was superior to brentuximab. It showed improvement in progression-free survival, 13.2 months with pembrolizumab and 8.3 months with brentuximab. So that's now giving us a sense of, which of these two classes, both of them are excellent, but which one of them is more excellent. And so that led to this frontline trial. And, I think you're fortunate to be here today because we really have to be on our toes when we're talking about these developments in lymphoma, because this trial was published literally yesterday. I read it this morning for the first time in the New England Journal of Medicine. So this is the SWOG S1826 trial. It was a phase 3 randomized trial of nivolumab with AVD versus BV with AVD in untreated advanced Hodgkin. So remember, BV-AVD sort of won out over ABVD in patients with advanced stage. And so now we're comparing nivo-AVD to BV-AVD. And the winner was nivo-AVD. The 2-year progression-free survival, 92% with nivo-AVD versus 83% with BV-AVD. And if you look at the side effect profile, there were fewer side effects with Nivo AVD. So it's the winner of this trial. And I would not be surprised if we see Nivo AVD emerge as our standard frontline treatment in Hodgkin's. Okay, now I'm going to move to the next immunotherapy, which is CAR T therapy. And again, this is very exciting, very new, and many people in the audience will have heard of this. So this slide just describes the process. So this is a patient who's connected to a machine which collects the blood cells, and it separates off the patient's own T cells. So patient's own T cells. Now those T cells are collected and they're sent to a manufacturing facility where a virus is inserted into these T cells. And the genetic makeup of that virus then incorporates into the genetics of the T cell, and it causes the T cell to express the antigen, express the antibody. And in this case, the virus has been injected with the antibody for CD20. So now you have these T cells that can produce CD20 antibodies. So remember, I talked about the bispecifics, I talked about the checkpoint inhibitors. Now you've got taking the patient's own T cell and inserting in a receptor in that T cell for the B cell, for the cancer cell. So those T cells that are now chimerized, they're modified, they get expanded in the lab, and the product gets sent back to the hospital for infusion into the patient. Now you have the patient's own T cells, so there's no rejection. The body recognizes them as their own. But their own T cells now have receptors for the B cell malignancy. So these T cells can get up close and personal with the B cells and cause death of those B cells. And so those cancer cells are destroyed. So it's really quite incredible. This table just very quickly shows sort of the main studies in diffuse large B-cell lymphoma. So there's three main products: Axi-cel, Tiza-cel, and Liso-cel. And all three products have been tested both in patients who have relapsed after auto transplant and in randomized trials comparing this treatment to auto transplant in first relapse of the disease. So ZUMA-1, it was the phase 2 of Axi-cel in patients with relapsed diffuse large B-cell lymphoma. So all of these patients have had prior transplant. This was a 100-patient trial at the time that this report was issued. An overall response rate of 83%. Over 50% of patients had a complete remission. 42% of patients were alive at 5 years. And if you were a responder, if you were one of these 83% of patients, 31% of those patients were still in remission 5 years later. So these are their survival curves. And when I look at survival curves, I'm looking both at where do things level off, so what percentage overall survival is about 50%. But I'm also looking at whether this curve is flat or not, because if it's flat or not, it means that as these patients move forward in time, there are fewer and fewer relapses that are happening. And so a flat curve here is essentially a cure. So about 50% of patients are being, well, about 42% of patients are being cured with ZUMA-1 with Axi-cel. So if it works that well in patients that are relapsing after auto transplant, the question then becomes, is it a better treatment than auto transplant? Because we know auto transplant is our standard, or was our standard second line treatment for patients with relapsed diffuse large B-cell lymphoma. So to explain that, if you have diffuse large B-cell lymphoma and you go through your first line treatment, which usually is R-CHOP, and then you relapse, the standard would be to undergo an autologous stem cell transplant. But the problem is that autologous stem cell transplant, it cures or provides durable remission in less than 40% of patients. So it's good treatment, but it's not excellent treatment. So ZUMA-7 was a randomized study of CAR T versus autologous stem cell transplant in patients that relapsed within 1 year of their first chemotherapy, so their R-CHOP. Now, again, the earlier you relapse after R-CHOP, the less likely it is that auto transplant is going to work. So they focus their energies on those higher risk patients that might not do well with auto transplant. And the results of the ZUMA-7 trial were that Axi-cel improved response rate, it improved the event-free survival, and it improved the overall survival compared to auto transplant. Again, looking at the survival curves here, there's three things that I want to point out. This is the percentage of people who are alive over time, and we're getting out to 5 years here. So the first thing I want to point out is that if you were randomized to Axi-cel, you clearly were more likely to be alive in 5 years than if you were randomized to auto transplant. So Axi-cel is better therapy. The second thing I want to point out is the number. So at 4 years, 55% of patients getting Axicell were still alive and in remission. And then finally, I wanted to point out the flattening of the curve. And so it does appear that when you use Axicell as your second-line treatment in these patients, you're getting a cure rate of just about 50%. Finally, with the CAR-T, I just want to mention that CAR-T has also been studied in follicular lymphoma and in marginal zone lymphoma. So the ZUMA-5 study looked at Axicell in those diseases, and it found an overall response rate of 94% and a complete response rate of 79%. Again, these are patients who have had at least 2 prior lines of therapy, where you would expect for most treatments, you might get an overall response rate of 40 to 60% and a complete response rate of 20 to 30%. So very good numbers, and it has led also to the approval of Axicell in third-line treatment of follicular lymphoma. So it's great treatment, but it has its problems. And the first main problem is this thing called cytokine release syndrome. So what happens when you take those T cells that have the receptor for the cancer cell, when those T cells attach to the cancer cell, they release cytokines, which is part of the way that, it's the way that they kill the cancer cells, but those cytokines also are very inflammatory. So it causes this massive release of cytokines within the body that can result in fevers, low blood pressure, and even it can lead to organ failure and death in some cases. So the severity ranges from mild flu-like illness, sometimes just fever only, but sometimes it's a severe life-threatening condition requiring intensive care unit. The management of cytokine release syndrome is with intravenous fluids, steroids, and medications that inhibit cytokines like this thing called tocilizumab. So cytokine release syndrome is an important toxicity of CAR-T. This is, I think if you compare the toxicity of CAR-T versus the toxicity of autotransplant, the CAR-T treatment is a little bit easier. It's more likely to be outpatient treatment. But if you develop severe cytokine release syndrome, then that can be a significant event. The second of these sort of specific immune-mediated toxicities are this immune effector cell-associated neurotoxicity syndrome. Now, the graphics that we use to explain what's going on here are very complicated, so I've decided to leave that out for this discussion. But this is a neuropsychiatric syndrome that's characterized by confusion, aphasia, and seizures. And the problem with it is unpredictable. It doesn't occur the day after the CAR-T treatment. Sometimes it occurs days or even weeks, up to 4 weeks, or sometimes even later than that after the CAR-T infusion. So with this treatment, which is not like chemotherapy where you're coming for repeated treatments over and over, this is one treatment. You get the infusion of your CAR-T cells and then you wait. And so a toxicity that occurs weeks later requires careful monitoring of the patients that have been to the center and have received the treatment. Fortunately, ICANS is usually reversible if it's managed appropriately, but sometimes, the confusion and the neurologic symptoms, the seizures, require patients to be sedated and even intubated sometimes. So intensive care unit can be involved. And again, the management of this includes steroids, anti-seizure prophylaxis. Tocilizumab, the anti-cytokine antibody, doesn't work as well for preventing ICANS. So how often do these toxicities happen? Well, if we look at that ZUMA-7 randomized trial in second-line treatment, any grade CRS happened in 84% of patients. So almost every patient had at least some CRS. Now, mostly it's fever, right? Fever would be grade 1 CRS. If you look at the proportion of patients that had high-grade CRS, that was only 6%, thankfully. And ICANS, it's a scary toxicity to consider that 40% of patients have at least, have any grade of ICANS. But again, fortunately, it's less common to be higher grade. So grade 3 or higher in this study was 21%. Still significant enough that we have to do CAR-T therapy in specialized centers that are trained in managing these side effects. So not every hospital will be able to deliver CAR-T therapy. Okay, moving now to bispecific therapy. So this is just a sketch of, one example of a bispecific antibody, which is called epcoritamab. So bispecific therapy works similar to CAR-T therapy, except instead of inserting the anti-CD20 antibody into the surface of the T cell, now you've got an antibody that has one arm that's an anti-CD3, which attaches to the T cell, and the other arm of the antibody is an anti-CD20, which attaches to the B cell. So it has two arms, and it brings the T cell and the B cell together so that their actions can happen. So some of the main drawbacks of CAR T, number one, it requires treatment at a specialized center, so it's not available everywhere. And secondly, the process of collecting those cells, separating the T cells, sending them off to be manufactured, and then waiting for them to come back, that can take 3 or 4 weeks. And sometimes these patients with relapsed diffuse large B-cell lymphoma, the disease is so active that you have to do something for those 3 or 4 weeks to keep the disease under control. And frankly, sometimes it's happening so rapidly that there isn't anything that we can do to keep it under control. So the beauty of bispecific therapies are that they are an off-the-shelf drug. So it doesn't require this 3 to 4 weeks. If they're available in the pharmacy, I can order it today and use it tomorrow. There are 2 that are approved and funded for diffuse large B-cell lymphoma in Canada, epcoritamab and glofitamab. Epcoritamab is a subcutaneous product, and when we use epcoritamab, the treatment is indefinite. So you get repeated injections every few weeks, and that continues for as long as it's working. Glofitamab, on the other hand, it's an intravenous treatment, so you have to come into the infusion center and spend longer getting the intravenous, but the total treatment is a fixed duration. So it's 12 cycles of treatment, which takes about 9 months, and then you're done. And then the other thing that's different is that the glofitamab requires a dose of obinutuzumab, which is a monoclonal anti-CD20 that's given 1 week before the first dose of glofitamab. Now, because these bispecific therapies do activate the T cells in the same way that CAR T therapy does, you do still have CRS and ICANS. And so in both cases, there's a ramp-up dosing schedule in order to reduce the risk of those 2 toxicities. So you start with an extremely low dose, and then an intermediate dose, and then the third dose is the full dose of the antibody. So I wanted to give you a sense of how well these work in third-line diffuse large B-cell lymphoma when you compare to other things that are available out there. And so right now, I didn't talk about these yet, but well, I did talk about polatuzumab. So Pola-BR is one approved therapy for third-line treatment. And then the second one is Tafa-Len. So these 2 columns here, these are looking at real-world results with polatuzumab vedotin, Pola-BR, or tafasitamab lenalidomide in third-line treatment. And these studies showed that in this group of patients, the average number of prior lines of therapy they had were 3. With the Tafa-Len, it was 2. 53% of these patients had 3 or more prior lines. 35% had 3 or more prior lines with Tafa-Len. Small proportion of these patients had prior autologous stem cell transplant. 30 to 40% had prior CAR T. These are the response rates. So in Pola-BR, the overall response rate in the real world was 40%. And the complete response rate was 24%, and the median length of those remissions, duration of response, was only 4 months with Pola-BR. With Tafa-Len, the overall response rate 26%, complete response rate 14%, and the median duration only 6 months. So Pola-BR and Tafa-Len are approved therapies for third-line treatment of diffuse large B-cell lymphoma, but they work in a minority of patients, and even when they do work, they don't work for very long. So keep that in mind. This is the phase 2 study of epcoritamab. So 70% of these patients had at least 3 prior lines. So these are patients who have been more heavily treated than the others. 20% had prior auto transplant. 39% had prior CAR T therapy. So those are about the same. The overall response rate here, 63%, and the complete response rate, 40%. And the duration of these responses were 15 months for all responders and 21 months if you had a complete response. And the overall survival of these patients, the median overall survival was 18 months. So this is a more heavily pretreated and more difficult to treat population, and yet the results of epcoritamab are far better than Pola-BR or Tafa-Len. And if we look at the phase 2 of glofitamab, really the results are the same as for epcoritamab. So 52% overall response rate, 39% complete response rate, duration of remission 18 months. If you had a CR, then when this study was published, the duration of complete remission hadn't yet been reached. So really, bispecific antibodies are replacing Pola-BR and Tafa-Len as your standard third-line treatment. Now I'm going to move away from the immunotherapies and talk for 10 minutes about targeted therapies. And I couldn't possibly cover all of the potential target therapies because you can see what's going on inside these B cells with these molecular pathways that are responsible either for turning on cell division or signals that are responsible for preventing the cell from dying. These targeted therapies work inside the cell on these protein pathways to inhibit them, and that's how they have their effect on the lymphoma cell. So I'll talk about 4 different categories: BTK inhibitors, BCL2 inhibitors, BTK degraders, and EZH2 inhibitors. So ibrutinib was the first of the BTK inhibitors. It's used in first-line treatment of CLL. When you start ibrutinib, it's used continuously, so it's used until it no longer works or until it's not tolerated anymore. There are classic side effects from ibrutinib, including bleeding, atrial fibrillation, hypertension, and serious cardiovascular events have occurred with ibrutinib. The RESONATE trial was a trial looking at patients over 65 who did not have a deletion of chromosome 17p. So this is an intermediate risk group of CLL patients who were previously untreated. It was a randomized trial of ibrutinib versus chlorambucil. And those patients that were put on ibrutinib and stayed on it, 59% of those patients were still in remission at 7 years. With conventional chlorambucil in those patients, that number was only 9%. So ibrutinib is an excellent treatment in frontline CLL. Ibrutinib has changed the standard of how we treat CLL. So this diagram would be a summary of how we treated CLL 10 years ago. So we divided patients with CLL into those who were fit. That was young patients, patients with normal kidney function and not a lot of medical conditions. You flip to the other side and you have frail. So that's patients who, generally speaking, were over 70, who had poor kidneys or other medical illness. And then you had a middle category, an intermediate category. So we call them fit, unfit, and frail. And for patients with fit, FCR was standard chemotherapy. For patients who are unfit, bendamustine and rituximab was standard. And for frail patients, chlorambucil and obinutuzumab was standard. Now, there were randomized controlled trials published 5 years ago in all 3 of these categories that were comparisons of ibrutinib with rituximab or by itself compared to the standard chemotherapy. And in all 3 cases, ibrutinib was superior. So ibrutinib is an excellent treatment in all 3 of those categories. Now, I talked about the side effects of ibrutinib. There is a second generation of BTK inhibitors, acalabrutinib and zanubrutinib, and they were designed to try to have similar effects on the cancer cell, but fewer off-target effects. So these are target maps, and they're a little bit hard to explain, but if you look at ibrutinib here, and you look at this target here in blue, that's the BTK. So that's active on the BTK. But all of these other red dots, these are areas in the cell where ibrutinib is active, but it has nothing to do with BTK. So those are called the off-target effects. And the size of the circle is sort of a measure of how much effect they have at those other sites. So you can see acalabrutinib was designed and it has less off-target effects. So all of this stuff here, this red, you don't see nearly as much of it with acalabrutinib. You still have the blue on the target, so that's the BTK target. And then you have a couple of new off-target effects with acalabrutinib that will give it somewhat different side effects compared to ibrutinib. Similar for zanubrutinib, again, here's your BTK target. You have a little bit of this off-target effect here and a little bit here. But looking at that sort of globally, that's a different profile compared to the acalabrutinib. So acalabrutinib was studied in the ELEVATE-TN trial. So TN stands for treatment naive. So this was patients who were 65 or older who have other medical conditions. And they were randomized to receive either acalabrutinib with obinutuzumab, or chlorambucil with obinutuzumab. And again, if you look at the proportion of patients who got acalabrutinib who are still in remission 6 years later, it was 62%. And even better with obinutuzumab. So acalabrutinib plus obinutuzumab at 6 years, 75% of patients were still in remission. This is really quite incredible. But again, it's continuous therapy. So they're in remission, but they're also still on their treatments. Now, acalabrutinib is approved in all provinces in Canada. Acalabrutinib in combination with obinutuzumab is available in some provinces, but not in all. But anybody in Canada can get acalabrutinib for frontline treatment of CLL. Then this is the study for zanubrutinib. So the frontline study in zanubrutinib is called the Sequoia trial. And this was zanubrutinib versus bendamustine and rituximab, again, in patients over 65 or younger patients who had medical conditions. There was shorter follow-up in this study, but again, zanubrutinib was clearly superior to the standard chemotherapy in this study. And at only 2 years, because we have shorter follow-up, 86% were still in remission. So both acalabrutinib and zanubrutinib have a better safety profile compared to ibrutinib in head-to-head trials. Those are the trials there. Elevate-RR was acalabrutinib versus ibrutinib, and the Alpine study was zanubrutinib versus ibrutinib. So one of the problems with the first and second generation BTK inhibitors is that patients can become refractory. And for most of those patients who have been on acalabrutinib for 7 years and now their disease is starting to grow despite the fact that they're still on the treatment, it's because that there's a mutation in the site within the cell where the ibrutinib or the acalabrutinib binds. So if you think of this is the BTK. Wild means wild type, so that's an unmutated BTK, and you can see that the ibrutinib or the acalabrutinib, they have a binding site that fits perfectly into that pocket. So as long as that pocket remains the same, the ibrutinib and the acalabrutinib will continue to work, and the zanubrutinib. But what happens is that you get a mutation in the binding site, and now the binding portion of the acalabrutinib or the ibrutinib no longer can fit in there, and therefore it can't attach to the cell, to the BTK, and can no longer inhibit the BTK. So these new generation non-covalent reversible BTK inhibitors called pirtobrutinib and nemtabrutinib, they work in a different way. So they don't bind inside the pocket. So they don't care if the pocket is mutated. They bind on the outside, and they bind in a different way. And so in patients with mutations of the BTK pocket who have lost their benefit from acalabrutinib, ibrutinib, and zanubrutinib, sometimes pirtobrutinib and nemtabrutinib can still work. All right, moving to BCL2 inhibitors, venetoclax. So venetoclax, it first was developed as a single agent in relapse CLL. It works very well. That's continuous therapy. Then it was looked at as a 2-year combination with rituximab in relapse patients. And then finally, it was investigated in first-line treatment of CLL as a 1-year combination with obinutuzumab, what we call Ven-O or Ven-Obin. So this trial was CLL14. It was ven-obinutuzumab versus chlorambucil obinutuzumab for just 1 year of treatment. And similar to the results with the BTK inhibitors, at 6 years, we have 53% that are still in remission. Now, if we look at the subgroups according to their genetic risk profile, so low risk are mutated IgHV, 72% of those patients were still in remission. But if you look at the highest risk, patients with either a 17p deletion or a p53 mutation, only 22% of those are still in remission. So this works extremely well for lower and intermediate risk patients, but less well for high risk patients. Now, the problem with venetoclax is it has this thing called tumor lysis syndrome, which can occur, and that's, frankly, it's a real pain, inconvenience. So tumor lysis occurs when many cancer cells all break down at the same time and they release their contents into the bloodstream. And that results in increased potassium, uric acid, phosphate, can cause kidney damage, and it can cause arrhythmias with the heart. And when they first investigated venetoclax in CLL, they had some fatal tumor lysis syndrome. And so what they realized was that you can't give it all at once. You have to go through this very slow ramp up where you start with 20 milligrams for 1 week, and then 50 milligrams for a week, and then 100 for a week, 200 for a week, and then finally you reach the final dose of 400 milligrams. And each time you ramp up the dose, you have to do blood work more than once a day. And so it's extremely inconvenient for patients to try to manage this, especially as an outpatient. So nowadays, we're looking at combinations of BTK inhibitors and BCL2 inhibitors, and we recognize that there is synergy. BTK inhibitors work very well to push CLL cells out of the lymph nodes into the blood. And then BCL2 inhibitors work very well on killing those CLL cells once they're in the blood. So if you combine them, you get this synergy. So Captivate and Glow were 2 studies that looked at the combination of venetoclax and ibrutinib. And those studies showed that this is an extremely effective fixed duration combination. And in the Glow study at 4.5 years, 60% of patients were still in remission after just 1 year of therapy. These are current clinical trials in CLL. I'm not going to go through the whole table because we're running out of time, but it's just to show you that there are many clinical trials now that are looking at one of the experimental arm is a combination of a BTK inhibitor with a BCL2 inhibitor. And here you see the BCL2 inhibitor has always been venetoclax until this final trial, sonrotoclax is a BeiGene product, which is a new BCL2 inhibitor. So moving to one of my last classes of medications, the BTK degraders. So rather than inhibit the BTK protein within the cell, why not eliminate it altogether? BTK degraders are drugs that attach to the BTK, and when they attach, they cause this thing called ubiquitination, and that is the addition of another protein called ubiquitin to the BTK protein. And when ubiquitin attaches to a protein within a cell, it marks that cell for disposal in the garbage dump, and the garbage dump is the proteasome pathway. So these are drugs that promote destruction of the BTK protein. There are two of them in development. This first one is called Nurix, or NX-5948. It was presented last June at the European Hematology meeting. They looked at it in 79 patients with non-Hodgkin's or CLL. And in the CLL group, most of them had refractory disease, had been treated with both a BTK inhibitor and a BCL2 inhibitor. Overall response rate was 69% in CLL. And you can also see responses in different non-Hodgkin lymphomas, so diffuse large B-cell, mantle cell, marginal zone, and primary CNS lymphoma. The second one is a BGB 16673, a BeiGene product. This was a phase 1 that was presented last December at the American Society of Hematology. 51 patients treated, 48% of them were CLL. And then there were a handful of these other types: mantle cell, Waldenström's, follicular, marginal zone, and diffuse large B-cell. A very refractory population. The overall response rate was almost 60%. And in CLL, the overall response rate was 70%. So extremely promising results with these BTK degraders. Lenalidomide, it's actually an old drug. It's an immunomodulatory drug that has been used in myeloma for probably 2 decades now, but it has been investigated in follicular lymphoma. The Relevance trial was a trial looking at lenalidomide plus rituximab versus rituximab plus chemotherapy in previously untreated follicular lymphoma. The chemotherapy was either bendamustine, CVP, or CHOP. And really, it showed that there was no difference. There was no difference in response rate, no difference in the proportion of patients in remission at 3 years. And there were different toxicity profiles compared to this. So this was referred to as a chemo-free regimen for frontline treatment of follicular lymphoma. It hasn't really caught on in Canada, but I think it's starting to catch on. It's not funded right now in most provinces in Canada. R-squared, which is lenalidomide and rituximab, or Revlimid and rituximab, has also been looked at in relapsed follicular lymphoma in the Augment trial, and also in relapsed diffuse large B-cell lymphoma. For the sake of time, I'm just going to skip through the EZH2 inhibitor, but just it's another protein that's intracellular that's responsible for controlling cell proliferation and cell survival. And when you inhibit it in cancer cells, you get benefit in terms of killing those cancer cells. So tazemetostat is a drug that's been investigated in follicular lymphoma. We'll skip to the response here. So this is patients with relapsed refractory follicular lymphoma, and responses were seen both in those who had mutated EZH2 and also wild type EZH2. So promising. I wasn't going to mention this at all. In fact, I was in the process of removing these slides this morning when this popped up in my email today. So you can see this was at 11:04 this morning. EZH2 inhibition of follicular lymphoma, overview analysis of the Symphony 1 trial. So it still has quite a lot of interest. So now in the last 2 or 3 minutes, I'm just going to show you how the treatment paradigm has changed in several different types of lymphoma. So we'll start with Hodgkin lymphoma. If you looked 5 years ago at how we treat Hodgkin lymphoma, frontline treatment was ABVD for patients with relapsed. They would get chemotherapy, usually GDP, followed by autologous stem cell transplant. If they relapsed after that, they would get brentuximab vedotin. And if they relapsed after that, they would get pembrolizumab or nivolumab. And so the data for those I showed you already. Now we have the frontline study, the Echelon study, that showed that BV-AVD is better than ABVD. So if patients are diagnosed with stage 4 Hodgkin's nowadays, they get BV-AVD. And just out of interest's sake, this study was in advanced stage disease. We're currently doing a randomized control in early stage disease, again, comparing BV-AVD versus ABVD. Patients who relapse after this now, there's a randomized control trial of BV plus Nivo compared to GDP prior to the autologous stem cell transplant. So can you get away with a chemo-free regimen before your transplant in relapsed patients? And then what happens to patients who might relapse after this? Well, it really depends on the situation. They might get BV again, they might get Pembro again, or perhaps they might even get a combination of those drugs. It depends on how they did with their first few treatments. So that's kind of the snapshot of what's happening now. Looking to the future, again, yesterday, the study of Nivo AVD versus BV AVD showed that Nivo AVD is actually better. So I believe that Nivo AVD will become our standard first-line therapy. And then looking at a chemo-free upfront regimen entirely, BV plus Nivo, without any AVD chemotherapy. There was a phase 2 of this study in previously untreated elderly patients that were thought not to be able to withstand AVD-like chemotherapy. So this phase 2 it wasn't a randomized study, it was only BV Nivo, and you see very high response rates. Now, those response rates are nothing near what you would see with frontline Nivo AVD, but it'll be interesting to see how that might catch on. And then now looking at patients with refractory or relapsed Hodgkin lymphoma, we have all of these sort of areas of investigation that are going to lead to changes in that disease. In CLL, again, 15 years ago, we had 3 categories of patients according to patient characteristics, dividing them into fit, unfit, or frail. And the Germans, who did a lot of this clinical trial work, they referred to these populations as the go-go, the slow-go, and the no-go populations. And these were the standard chemotherapies, FCR, BR, and chlorambucil and obinutuzumab. Now we don't do that anymore. Now we divide patients according to the disease characteristics of their CLL, looking at their genetic risks. So mutations of P53 or deletion of 17p, that's a high risk. Those patients should get a BTK inhibitor as their first line. Patients with unmutated IGHV, that's an intermediate risk. And in that case, they should get either a BTK inhibitor or venetoclax obinutuzumab. And in mutated IGHV low-risk patients, those patients do very well with venetoclax obinutuzumab, but in some circumstances, you may want to choose a BTK inhibitor. And that's where patient preference really, I think, comes in. Do you want continuous therapy BTK inhibitor for life, or do you want 1 year of time-limited therapy with venetoclax obinutuzumab? And I think what we're moving towards is time-limited combination BTK and BCL2 inhibitor therapy, and that would be for all risk categories. I think that's what I see in the future for CLL. Diffuse large B-cell lymphoma, again, the standard 2 years ago would have been R-CHOP or R-EPOCH as your frontline treatment. For those that relapsed, GDP followed by auto transplant, then a CAR T after auto transplant, and then Pola-BR or Tafelen after CAR T. Nowadays, we're debating whether Pola-R-CHP should be used for a portion of these patients, but R-CHOP and R-EPOCH still stay there. Now, if you have a long first remission and a late relapse, then GDP and auto transplant is the right treatment for you. If you have a relapse within 12 months, then you should get a CAR T in second line. And then what you get in third line really depends on whether you've already had CAR T or not. And then Pola-BR and Tafelen kind of become fourth line treatments. What we're investigating now are combinations of bispecifics with chemotherapy up front. If Pola-R-CHP is better than R-CHOP, then a bispecific with R-CHP should certainly be better than R-CHOP and may be a winner. Those clinical trials are happening now. There are new CAR T products with different targets. The main targets right now for the B cell at least are CD20 and CD19, but there are other possibilities. And then we look at all of these novel therapies as potential subsequent treatments in refractory disease. And then finally, in follicular lymphoma, again, the tradition has been to give bendamustine and rituximab with or without maintenance rituximab. Most patients have a very long remission of 7 to 10 years or more. And in those cases, you would consider giving chemotherapy again, maybe benda with rituximab again, maybe benda with obinutuzumab, maybe R squared, maybe something like CVP or CHOP. 20% of patients, though, do not have a long remission after bendamustine rituximab. They relapse within 24 months. We call that POD24. Those patients should be getting autologous stem cell transplant in second line. And I can't even begin to draw a flow chart for what might happen for patients with relapsed refractory follicular lymphoma, because all of these treatments now are becoming studied options.
Thank you, Dr. McDonald. We'll just take one question for the sake of time. Is Nivo also used to treat CD30 just like BV?
So BV is a targeted therapy where the antibody is targeted specifically for CD30. So that's why BV is a CD30 treatment. Nivolumab doesn't care what the target is. It doesn't attach to CD30. It doesn't attach to CD20. It attaches through the PD-1 mechanisms. So patients can be CD30 positive or negative. As long as they have PD-1, then nivolumab is an appropriate treatment choice.
Thank you for that overview. And now I would just like to direct the audience to attend the subtype specific breakout sessions. Please be sure to select your specific subtype, whether that's Hodgkin lymphoma, DLBCL, follicular lymphoma, CLL, Waldenstrom's, or CTCL. And those sessions will be followed by Q&A sessions. So you will have the opportunity to ask more questions. Thank you, everyone, and I hope to see you there.
Thank you.